Yeah, no, it's it's my pleasure to introduce Leyla Larsson, who's from the London School of Hygiene, who's visiting with Rashida, who's also here from the School of Hygiene, and going to tell us about this study that is being set up in Zimbabwe at the moment. Leyla.
Thank you, George. Hi everyone, thank you for having the two of us here. We've already had such a wonderful morning, Chef. Hi everyone online. We've had such a wonderful morning speaking to some of you. It's been already so nice, so thank you so much. And I'm here today to tell you a bit more about the PROMIS trial, what we're doing, some exciting plans and what we have for the future. And I just want to say I'm the one standing here and Rashida's here, but we're speaking on behalf of a massive team who's busy making this all happen. So it's really been a group effort. But what I wanted to talk about today is a bit about PROMIS, the trial itself, but also about how we can leverage what we are collecting and the actual cohort that we have to do really exciting studies. So just a bit of background on why we actually are conducting PROMIS and how it came about. So there are a lot of STIs globally and the control is really poor. And when you think about this, over 1 million infections occur every day, which is a lot. And in 2020, the WHO estimated that 374 million infections of one of the 4 curable STIs. There you go. Perfect. So chlamydia, gonorrhea, syphilis, and trichomoniasis. And a lot of these infections you can see on the graph occur in the African region where you have 96 million infections in 2020, incident cases. Great. And in terms of the rationale of why you would screen in pregnancy, there hasn't been much evidence. So most of the evidence that comes is from observational studies. And so you found that there's been an association between maternal chlamydia and gonorrhea infections and an increase of preterm birth. And so you can see that there's a small adjusted observation of chlamydia of 1.03 and 1.11 for chlamydia and gonorrhea, respectively. And some systematic reviews and meta-analysis data indicate that there may be also an increased risk of prematurity and some other adverse outcomes for trichomoniasis. But these are data coming from observational studies, which are obviously prone to residual confounding, and there's little evidence actually supporting routine screening for these STIs in pregnancy to prevent these adverse birth outcomes. There has been one trial which has been conducted in Papua New Guinea called the one-time trial, and this was a pragmatic cluster randomized crossover trial of a point-of-care STI testing and comprehensive management versus standard of care, which is syndromic management, which means that you essentially just treat when you have symptoms. And keep in mind that only about 10% of pregnant women have symptoms, or people with STIs have symptoms. And so they recruited just over 4,500 pregnant women aged 16 years and above attending at genital clinics 26 weeks or earlier. And what they found was that the proportion of preterm birth, low birth weight, or both in the intervention group was almost 19%, compared with 17.8% in the control group, so a 1.06 risk ratio. And there was no reduction in the risk of low birth weight or prematurity in the overall population, but they did found an association in the group with gonorrhea. Now, with that, we have PROMIS, which we're implementing the study to actually hopefully be the conclusive study to investigate the impact of screening comprehensive management of STIs in pregnancy on these adverse newborn outcomes in a high HIV and STI prevalence setting. We have three objectives. So one of them is to look at the effectiveness of screening for these treatable, curable, in treating of these curable STIs and reducing the risk of preterm birth, low birth weight, and stillbirth, including other adverse outcomes. We'll also be looking at the cost effectiveness of this strategy. And then finally, we'll also look at the community needs and the feasibility to maximize acceptability and uptake and implementation success. So what we are doing is our study design setting is in Harare. We have an individually randomized controlled trial where we will be testing for chlamydia, gonorrhea, and trichomoniasis coupled with comprehensive management against the standard of care, so similar to one time. But here we are recruiting 12,780 pregnant women attending antenatal clinic, and here the inclusion criteria is earlier than 24 weeks, which is predominantly for pragmatic reasons, but also intervening early in pregnancy might have a better outcome. So our setting is a bit different than the one time. Here we have a higher HIV prevalence. We are also implementing in the public sector, so in antenatal clinics, and I've already mentioned that the standard of care is syndromic management, and our testing is not point of care, and instead we've opted for a hub and spoke model of testing with a national reference laboratory, which is in the public sector. A bit about our intervention. So we are visiting the pregnant women twice during pregnancy. So once at enrollment, which is before 24 weeks of gestation, and then once again in the third trimester between 32 and 34 weeks of gestation. In our intervention arm, you are tested and, if positive, treated at both visits for chlamydia, gonorrhea, and trichomoniasis. In the control arm, at the 2 visits, you follow syndromic management, so you're only treated if you have symptoms, but we are collecting vaginal swabs from these women, and they will be tested at a later time. So you can see here we have our 2 visits enrollment in the trimester, and after birth, we treat the women in the control arm if they were positive but not treated syndromically during a pregnancy. And so when I say comprehensive management, this is not just antibiotic treatment, but this is also risk reduction counseling, partner notification, and and also provision of condoms if needed. We are integrated in the public sector, so if they are newly diagnosed with HIV, we will link them to HIV care, and we will follow standard care in terms of syphilis testing and treatment as well. So to talk a bit about outcome ascertainment, so you can see here, these are the 2 intervention visits I've spoken about, the enrollment and third trimester. Importantly, we're doing an ultrasound scan at enrollment. This is to establish an accurate measurement for gestational age. And then we have 3 outcome ascertainment visits, so one at 72 hours following birth, one 1 week, and one 6 weeks following delivery. And so we'll ascertain our outcomes and collect our data in a multitude of ways. Now, our primary outcome, which I'll talk about later a bit, is a composite of preterm, low birth weight, stillbirth. We will measure the birth weight ourselves. We have an ultrasound for gestational age, etc., to get the highest quality data. Then we're also extracting data from medical records, birth registers, infant road to health cards. This is where all the vaccinations are written, etc. So we're doing all kinds of data extraction in those 3 visits. So as I mentioned, these are our primary outcomes. And our secondary outcomes we have on the maternal, birth, and infant level. So on the maternal level, we're looking at the proportion of women who have curable STIs diagnosed but also treated during pregnancy and pre-labor rupture of membranes. Each component of our composite primary outcome will also be analyzed individually as a secondary outcome. And we're also looking at neonatal death and further on neonatal conjunctivitis and clinically-defined sepsis. I've spoken a lot about the main trial. So that is the gist of PROMISE, looking at the impact of STI screening on these adverse maternal and newborn outcomes. Now we are recruiting 12,780 participants, and it's an amazing platform, so it's sub-studies. So we've already implemented quite a few, actually. So one of them, the first one, will be looking at validating a fetal growth monitoring module using the ultrasound. So I mentioned we're doing ultrasound at enrollment. This is actually an AI ultrasound module, which is to be used by non-trained non-ultrasonographers. We will also be looking at genital inflammation, so doing proteomics and cytokine analysis. We will be looking at heat stress in pregnancy, and also looking at food and water insecurity, so more environmental and climate factors. There's a cohort study investigating the epidemiology of neonatal conjunctivitis, which is a sequelae of maternal STIs. We will also be looking at the genetic epidemiology of STIs and microbiome profile associated with these outcomes. We will be looking at the impact of inflammation during pregnancy on neonatal outcomes, a cohort study of syphilis exposed children, And then finally, the one I will talk about a bit more today is looking at understanding the drivers of adverse newborn outcomes using a causal systems framework. And this is where leveraging a platform and understanding all the drivers of one system comes into play. So when you think about the drivers of small vulnerable newborn, this is an image which was adapted from the new Lancet Commission on SVN. And you can see that there are an incredible amount of drivers of these outcomes, such as small vulnerable newborn, which is a composite of preterm, or is measured using preterm, small for gestational age, or SGA, and you can a combination of preterm SGA. So in this graph, you have your exposures, which are grouped in undernutrition, infection, morbidities, participant characteristics, and other exposures. And then you also have your context, which goes more to your health system, the agriculture, WASH, and general education, society, and culture. So you'll see I've overlaid promise onto this. So all the ones which have a little circle in front of them here, or maybe I should do this. So a little circle here, reflect data points which are already collected as part of promise. The ones which have stars in front of them are data points which we could potentially collect that would require additional funding. And then the triangles are the ones that we probably will not be able to collect as part of the study. And what you can see here is that we are collecting a huge amount of drivers of these poor outcomes. And this is taking SVN as an example, but there are other adverse outcomes where you could apply the same kind of multi-driver approach to. And so this shows that you do have many drivers of adverse outcomes, but these do not occur in isolation. And it is really important to understand that they do occur in a complex and, importantly, a dynamic system. So this is an example, and I can see that using light colors was a terrible idea, of a causal loop diagram. There are arrows in all directions. It's supposed to look very complex. I see here it looks quite simple now. But the point is that different variables and different factors interact with each other, and changing one exposure will change the effect of another exposure on your outcome. And so there are many ways to model this, but traditionally, most epidemiological studies will do, especially when you look at your causal inference framework, your one exposure and your one outcome, and using your direct acyclic graph, you will adjust for confounders, hopefully not for colliders, and move on. But what we are thinking with some of the maternal and child health research is moving towards is looking at these more in the system and combining your systems thinking approaches with your causal inference strategies and looking and trying to understand this wicked problem. And so this is where the platform thought of promise comes in. So I've talked about the trial, but it really is a big cohort because we're collecting a lot of data. We're doing this repeatedly. And so this is what I'm talking about, that epidemiological research has traditionally isolated these single exposures and outcomes, but it really doesn't reflect the reality of pregnancy, which is characterized by so many co-occurring exposures and issues, and importantly, feedback loops as well. And so this proposal here is really talking about leveraging all the data we are collecting, and to do three things. We want to quantify the direct and mediated causal effects of STIs on here SVN as an outcome. We also want to characterize a broader causal architecture of this association, how infections, nutrition, and any other health system factors interact to define this risk. And also using this causal systems approach will help us define and design multimodal intervention strategies across these modifiable risk factors. And so this is my last slide, and I would like to leave it up as we continue the discussion. And this is essentially showing the data that we're collecting in PROMISE. So you can see at enrollment, we're collecting a whole host of data on sociodemographics, clinical history, obstetric history, HIV and STI status, anthropometrics, environmental factors such as heat, water, and food insecurity. In blue is something I've highlighted that we're not yet collecting, but you can see how nicely it would add to this comprehensive picture of pregnancy health. And you can see that these measures are often repeated. Some are not repeated, such as obstetric history and clinical history, because you wouldn't need to collect it more than once. But the idea is that we want to be able to paint a big picture, and we have an opportunity here to do this. We've only just started recruiting, so I've talked a bit about the trial, but we started recruiting about a month ago now. We've recruited almost 500 participants into the 12,780. So some 500 feels like a lot, but we have a long ways to go. And so now is really a time to think about what we can add to leverage this platform and to paint a big picture on promise. So with that, I will stop here and invite questions, because the reason we are here today to talk is really to understand. I am definitely not a genetics, epigenetics, or any expert. And we would love to hear from you what we can do, how we can better understand this causal system picture of the risk and links with adverse birth outcomes, and what we can do in the study to be able to answer these really complex questions, and especially how to analyze it. This is an incredibly amazing group of people. We've already, just in this morning, we've learned so much. So it'd be really great to hear if you have any suggestions on what else we can do and how we can analyze it. And obviously, happy to chat more. So thank you very much.
Thanks. Yeah, so as Leyla said, you're here to discuss possible add-on projects, for example, and and you're obviously considering collecting additional data of these ways of getting those funded. Have you been getting? Have you been trying to get blood spots off the people you have recruited?
Yeah, so that was an excellent suggestion that I had recently. We are planning to add dry blood spots in the 3rd trimester. This is because since we've already started recruiting, we will miss the enrollment visit of some participants, but hopefully we can make the 3rd trimester of everyone already, maybe not the first few, but that is the plan. We can add dry blood spots. We just need to find out what to do with them as well. Taking them we can easily implement this, and we have space to store it. It's just we need to understand what to do with them and what would be not only feasible, but provide the most appropriate information, I guess.
Yeah.
And I don't know, Rashida, because I think you'll be able to answer all these questions better than me.
I think that's right. The idea came from you, George, in terms of why don't we add dry blood spots. I think collecting sort of samples, plasmas, or blood samples, and storing them is, from an operational point of view, much more challenging in such a large cohort, but we know that we can provide, we can do dry blood spots. I guess now what we're here for today is to explore collaborations and partnerships and joint grant applications. If you assumed as a baseline that we've got all this data available and we've got the dry blood spots available, for us to collect dry blood spots, we'll have to put an amendment, and following George's suggestion, we already have drafted the amendment, which is ready to go. But it's very helpful if we can explain to the ethics committee a little bit more specifically. We have currently put in a very broad idea to them, what we're going to do it for. It also makes it easier for us to plan flow of samples. Yeah. And there are a number of calls coming up. So there are discovery awards within Wellcome. There is also a genomics grant that has just been advertised by Wellcome. So we already have existing collaborations with Bristol, but the reason we are here today is both from a systems thinking perspective, the genomics perspective, epigenetics. This is the place it all happens.
It's such an interesting study. Thank you very much for coming in and talking to us about that. I was wondering, as you have specific interest on micronutrients, if it would be worth considering doing a metabolomics analysis where you would get information on loads of micronutrients, maybe not in a clinically validated way, but still that the comparison with the groups would work well. But also get a lot more information on molecules that could tell you about potential mechanisms of the intervention, for example.
Yeah, absolutely. This is where your expertise comes in. And I think having this information would be, especially if I guess it would depend on the research question that we're trying to understand, whether if we can definitely add the metabolite, I don't know how much it would take. The question is it there to paint the big picture of in the system, and if the micronutrients, we put it there, we don't really, so essentially we don't really know how to measure nutritional status. So we have our anthropometrics, we have a dietary diversity questionnaire, which I put in there, and so we didn't know if that was enough. And so if metabolomics would be able to paint this big picture of nutritional status, that would be amazing, especially because then that would be able to add it in. I don't have the expertise to say if it would, but if it does, and if it's possible to do on the DBS, I think that would be really interesting. And whilst I have spoken a lot about this systems thinking, I think the other interesting thing about this trial is that we are doing it on these curable STIs and adverse pregnancy outcomes. And we've said, and we've talked about how the observational studies have shown an association, but we have no idea mechanistically how these STIs could have a causal effect, because gonorrhea and chlamydia and trichomoniasis are all local, and they can become systemic, but most of them are confined to the cervical vaginal area. So we don't really know how these could cause, if they do, prematurity, low birth weight, etc. So maybe something molecular, like you suggest, could provide a bit more of that mechanistic understanding, which is a bit of a slightly different question than the systems one, but still equally as important and interesting. So if that's something that we could understand better through doing those kinds of analyses, I think that would be amazing. I don't know, Rashida. Yeah.
I think it would, and I think, as you said, more from a mechanistic understanding, but with potential to inform therapeutics. So to give an example, we are doing quite a bit of work here in the unit trying to understand which proteins and metabolites are causal drivers for some adverse pregnancy and neonatal outcomes. And if you can understand how a type of infection might influence these molecules, this might give you insights on potential drug treatments, because many of these molecules, particularly the proteins, are targets of drugs. So that's an example of how the more epigenetic work could link up well with an RCT with more molecular data that could point you to this kind of mechanisms. Okay. And I'm happy to discuss more in another time if you think that might be useful.
Well, how do you measure those? Can you use blood spots to measure some of the metabolomic?
I'm not sure actually, but
You can do.
You can?
Yeah, Olink,
That's been gone, yeah.
Olink and Nightingale got together and they have a card that you can track blood spots in.
Oh, it just said me.
Yeah. Yeah, so you can collect it remotely. So collect them, and then you can proteomics and metabolomics and according to them, you can also get DNA off of it, so you could DNA methylation.
Yeah. I've forgotten about that. That'd be worth looking at exactly what's special about that card. It probably costs 10 quid. That's funny then.
Just how much does it cost?
I don't actually. I'd have to check. Costing it.
Yeah, you mean for the Olink panel?
No, for the Olink card.
Oh, for the Olink card. No, I just have costs for Olink panel.
It's not, it was surprising. I don't know the exact number, but I was surprised that it wasn't as more than it was.
But the card is blotting paper, presumably, isn't it?
Yeah.
I mean, that's all, I think that's blotting paper for, so it'll be worth finding out whether there's something special they put in the card, which it helps keep the samples. But I mean, definitely the dried blood spots that are taken for PKU, I don't know if that's done in Zimbabwe, but the ones that are taken in Europe and the US, etc. I mean, in the eyesight study, they eluted those and measured substantial proteomics on eluted blood spots. So I can't see any reason why that wouldn't be the case. And you can certainly use them also for antibody panels for the Heidelberg antibody panels. So.
And the antibody panels would tell you about previous FPI?
It would only tell you about viral STI, but you could get all the human herpes viruses, hepatitis, and you can get respiratory viruses, and I mean it will reflect obviously the mother's antibody status, but the mother's antibody status is exactly the same. The infant at birth has precisely the same antibodies as the mother because they cross, and that's what you get from cord blood. That sort of disappears at 6. They wear off for about 6 months.
Mm. So it's the genetics measured from the salivary gland?
Sorry?
The genetics, how do you collect the DNA?
Oh, we're not measuring genetics as of now. That is a query that we could, but it would be yes.
I guess the big question is, there are lots of options of what one would measure. What would one want to prioritize? Yeah.
Hi, yeah, thanks for sharing the project. I'm just curious, since there could be potential SDI treatment in this cohort, and I'm just thinking that whether you have any discussion about to include like gut microbiome in models and fetus or even the neonates.
And what would be the main question? I guess the impact of antibiotics, or
any like effect of the treatment on the gut microbiome, and also gut microbiome has been discussed as a role in, like, there's a potential role in adverse health outcomes, especially in terms of the metabolic diseases, obesity. So I'm not so sure whether there's any potential to look into here, since there could be antibiotics treatment in this cohort.
The antibiotics it's a start dose.
Yeah.
You're not doing courses of antibiotics. I'm sure that there is some change.
Yeah.
Will be transient. With respect to microbiome, what we are doing is looking at the vaginal microbiome in terms of what STIs do to the vaginal microbiome.
But I'm just thinking about like other effects on the gut microbiome because of the treatment.
Yeah, I think that's not. I guess we're not going down the route of looking at the effects of treatment, but rather looking at whether what the underlying determinants of bad outcomes are. Yeah. Because only a small proportion of women will get treated.
Right.
But it's not looking to see whether the treatment of the infection drives those outcomes, but rather what factors generally drive the outcomes.
Yeah.
And that's why we're looking at the vaginal microbiome.
Yeah. One of the questions has been like, I'm not so sure about the updates, but for example, the neonates who had been treated antibiotics were associated with high risk of obesity in later life. So, and I'm just thinking about whether there's any chance to actually look into this.
Yeah, it's not long-term follow-up, but we'd be looking at infants growing into. I think it's kind of looking at what exposures we have in the mothers, maybe to collect now, and how that influences fairly collected birth outcomes. I think looking at the longer term sort of obesity and those kinds of outcomes would be outside the remit of the study, because we need longer follow-up. And it's not, for example, like the ASFAC cohort, we had long-standing cohort. We don't have that. What we do have is the potential of having a large cohort of pregnant women and how one can exploit that opportunity. Because those cohorts don't really exist in Africa.
Yeah.
And rates of stillbirth and prematurity are exceptionally high in this setting, and have declined for ages. And whilst it looks like we understand why it is, we understand, as Leyla said, very much from the point of view, yes, we know diabetes does this, so yes, we know hypertension does it, yes, we know infections do it, but, you know, the people are not there in isolation. And so we are only dealing with individual health problems rather than the fact that all of these issues are often overlapping, that they're all very common. The same women who are getting infection are also, very many of them also have hypertension, but all the interventions are very single focused.
Do you know much about the family structure of the individuals who recruited?
What do you mean by family structure?
Is there any siblings or cousins or other family relatedness? Or do you have will you be collecting any family histories? So if the mothers had particular STI histories. The reason I ask is there's a huge gap in the amount of evidence on heritability and genetic evidence for neonatal measures and for early life infection. And so if you did have relatedness, then we could start to estimate heritabilities, which would sort of be interesting.
I mean, I guess it depends on heritability of what. I mean, infections, sexually transmitted infections will not be heritable. They can inherit it, if you will. So we just dropped the question about previous STIs because remember this is a setting where nobody gets tested for STIs. I mean, STI testing is not the norm. The norm is if you get a symptom, you get treated for everything that would cause that symptom, which is syndromic management. And one of the reasons why these trials are now happening is because new diagnostics are being created that are relatively simple to implement. So if we asked whether they've been treated for previous STIs, often people don't know because people don't get tested for STIs. They just haven't been. They just treated syndromically, and only a minority of people who've got STIs actually get symptoms. And in terms of other STIs, I mean, people would know about whether they've been treated for syphilis and HIV, because that's the only thing that can get screened. So in terms of heritability of other diseases, I think we're asking about whether they've got family history of anything, Leyla?
Not asking about family history, but whether they previously had, if they've previously had pregnancies that have had any of the adverse birth outcomes, and whether they themselves have chronic hypertension, diabetes, other infectious diseases like TB, etc. But nothing in terms of family history, no.
Thank you, Leyla, for giving us such a lovely overview of the study. I wanted to ask a little bit about the mental health angle that you're thinking of. One thing I was wondering about was the kind of existing facilities. So if you start probing whether or not there's existing psychiatrists or help that you would then be able to funnel your participants to. And secondly, I wonder if part of the questionnaires would include questions around domestic violence and other stresses, which maybe I can't see as part of the platform at the moment.
It's a great question, and we have done one thing. We're very lucky that very close to our office is this organization called SALT, which is Someone Always Listens to You, and they're a maternal mental health organization, which worked out really well. And what we've done thus far in Promise is we've set up that anyone who experiences bereavement, we have set up a referral pathway to them, and we have a collaboration with them where they provide, hopefully in-person, first aid mental health counseling. So once one of our participants experiences the bereavement, the same day they're seen by this counseling service. So it's more of a first aid approach to things. We've had one participant referred thus far because she had a previous miscarriage but clearly must have been enough for her to mention in her visit that this participant was still referred. In terms of screening for mental health, we're not doing that just yet. There are a couple questionnaires. There was the Edinburgh Depression Scale that we considered using, and part of it was exactly that what do we do if we do these questionnaires? I mean, obviously the right thing to do is to refer people on, and it's just something we've not built in yet. Part of it is also because it also takes funding and takes investment. And so that's not something that we've done yet, but it would, if we were to explore adding in questionnaires, it would be something around IPV, because there is a certain amount of intimate partner violence, and it would probably be also that, but we'd have to explore exactly which scale is best and which one's been validated and used in them before. So it's something to explore, but that we've not done yet. They would have to be coupled with adequate referral too.
There was the recent call from Welcome around mental health and heat, and they actually said they sort of wanted the cohorts that were, or the projects that were applying to it, to use a set number of questionnaires. So they've all now been funded. I know for sure there's one list I remember in that group that were funded. So perhaps it'd be good to look at what they're using and see, because then you can do some cross-validation in different settings as well.
Yeah, I guess the one practical thing that is whatever we decide to collect, there are two considerations. One, the feasibility of collecting it validly and completely, like mental health, and you say questionnaires, etc. And then, of course, if it's something that one can intervene on, we ensure that we do intervene. That's one consideration. And in terms of, for example, blood samples that we collect, having some sort of plan to, I mean, even if we may not have funding, a plan that we will apply for funding. I guess because biobanking in our setting is so, collecting, biobanking, transporting is such a massive endeavor that one of the things, I mean, there's so many brilliant ideas, but it's what are we going to prioritize that we invest the dried blood spots in? We did collect dried blood spots for 16,000 young people, and we've got those dried blood spots. I mean, they were for HIV viral load, but there are 4 dried blood spots, so 3 dried blood spots left over. I mean, they're sitting there. There's a cost attached to all of these things. There's power supplies. I mean, this having we have again. So I guess the question is going to be, and where, I mean, the interest is from a kind of ultimately you want to improve human health. So it's either going to be understanding mechanisms or understanding what drives things so we can put multimodal interventions in place. And the answer to the question of the mental health is particularly tricky, because I do think it plays a potentially a role in driving those four outcomes in so many ways, indirectly or directly. The question is, if you identify it, you can't, I mean, ethically, I just don't think we can bury our heads. And the problem with screening questionnaires is they screens, so you're going to get a lot of false positives. But then what do you do with them? And services are poor. So trying to collect, we're not collecting. Sorry? So then the reality is that you then have to be really careful and thoughtful about what you collect. And we're hoping that you can help us think through what we collect. And of course, there's a burden attached to collecting all of these questionnaires in such a, this is already a lot of data, all in one setting, which is all complete with no missingness in it. But we've been very, very careful about what we add in to ensure that if we're talking about HIV status, we have HIV status for everybody. But it does mean that every 1 week, we're looking at records of 1,000 people. So it's really, I think what we can sell to collaborators and partners is that the data is really high quality, which is not often the case in large cohorts coming out of these settings in reality. But it's it's really effort intensive. Yeah.
We have a question. Just wondering if you have an interest in congenital anomalies in relation to the STIs that you'll be shaping.
As in, are we collecting congenital anomaly data.
Yes.
Yeah, so part of the labor and delivery outcomes we're collecting is we're actually taking pictures of the outcomes, which includes all of the information of whether anomalies arise. And this is not part of the primary secondary trial outcomes, but it will absolutely be analyzed in this data that we are collecting. There are no pre-planned analyses thus far specified for it, but it would be incredibly interesting to look at because that could be one of the potentially causal mechanisms which could arise. Yeah.
So wondering, with this really rich amount of information that you are already planning to collect, and maybe I missed that from one of the sub-studies, are you thinking about seeing if all this granular information can improve the current models used for risk stratification of common adverse pregnancy events like gestational diabetes or preeclampsia?
So you mean predicting preeclampsia or whether preeclampsia leads to poorer outcomes?
Predicting.
Predicting preeclampsia?
Yeah, if you can, with all this information, get a model that does better than what is currently used in many countries based on very established factors like previous obstetric history, ethnicity, maternal age, BMI, etc.
I mean, we could certainly do that. If we could use and improve. Yeah. That certainly would be a possibility. The only thing is that by the time they get to you, they probably already have their preeclampsia, you know what I mean? So, if you want to predict it, you want to predict it much earlier in advance. You could look to see if the risk was cross-validated, but I don't think we're achieving an earlier prediction in terms of discerning.
Yeah, absolutely. But I think still for some outcomes like preterm birth, for example.
Yes, that's exactly what so definitely that's what you want to do is understand what predicts preterm birth. I mean, as you saw in the list Leyla presented in the Lancet, so there's a whole lot of list of things, but what do they mean? I mean, what do these mean? Where should we intervene? Which ones should we screen for? Currently, what happens in antenatal care is women get a blood pressure, they get a weight, and they get an HIV test and they're lucky a syphilis test. That's about the level of, I don't know, Anna, whether that's the same in the Gambia, but
They wouldn't get their blood pressure checked. They wouldn't get their hemoglobin checked. They wouldn't get their urine checked.
no, they don't get, yeah. So it's, so you're not doing, so what is it that we could institute as a very basic is where we want to go?
I think that sounds very relevant. And also the fact that you have two measures, I also think is a major strength of being able to reassess people at a later point.
Yes. Yeah. What's the how? How do we do it?
That's actually something I wanted to ask. A prediction model, it's a very crude way to say it, but you just throw everything together and you use your output. But to do this multiple exposure association using multimodal data, so not just, numbers and categories, but also genetic data, I don't even know how to do that. And I was wondering if there are any suggestions on multiple exposure causal inference analyses that you would have, or where to go with this kind of trying to build in the causal inference and the system. Because causal loop diagram is all fine and great, but it's conceptual, and you don't have actual numbers on any of the nodes, any of the edges.
One thing that I can think is like loss of infections or something, and they identify a genetic instrument. I'm just talking out loud because I'm sluggish. So you get your genetic factors associated with infection risk and use those as an instrument to causal inference analysis to with outcomes. But And you also need the jewels of the article. You see that? You could use like the jewels of birth weight or something.
I mean, you're involved in the sort of birth outcome buses, aren't you?
Yeah.
What sort of volumes of data from Africa are there?
It's more just a few thousand cases. So the size of the jewels at the moment are like for common things like gestational diabetes, preeclampsia, 20-30,000 cases. But then from African ancestry, that's more like a few thousand. We are now doing a process of jewels on hypertensive disorders of pregnancy, and that includes a lot of data from the US. So we have people of African ancestry, but they are US citizens.
Yeah, I mean, all I can tell you clinically is that hypertensive disorders of pregnancy is an incredible problem in our setting, incredibly common. Again, I don't know if you saw that in the Gambia, but it's really, yeah, and because we don't know that much about it, most women are presenting very late at labor, and that's when it's sort of being picked up and addressed. There's a lot of problems that. Yeah.
Can you ask whether you're collecting any data on the paternal side?
Like what?
I don't know, just like any paternal history. I mean, because isn't the placenta driven a lot by the maternal side?
Mostly socio-demographic, but, and I mean, again, it's the quality of this data. We're asking whether their partner has ever been treated for an STI. Actually, probably, no, we moved that question. Yeah, we moved the question.
Yeah.
We used to.
Yeah,
It's
poorly, this really poor recall. And, asking a woman as a primary informant about what a partner has history. Yeah. But largely the data comes from a woman. So
there's other things like paternal age or kind of age.
yes, we have to. Yeah. We do.
not on the.
Yeah. Yeah, but we have that. It's just we don't know the history of the partner.
And we know briefly about the relationship, paternal age, whether they wanted to become pregnant. And then I think partner education, employment, and socioeconomic status.
Yeah.
That's it. And whether they take up partner notification, which I think is an important indicator as well. Any other thoughts? Hi, Tab.
Hi there, nice presentation. On heat exposure, what are you assessing? Absolute temperature? Oh, is that what you're measuring? Heat exposure?
So we've got absolute temperature. You have to correct me if I'm wrong. But there's also pressure. There's 4 measures in the Kestrel drop that they collect: is pressure, absolute temperature, dew point, and
from that they calculate the heat index.
yes, there you go. Yes.
Any assessments on coping mechanism? Given the context, like some have, mechanisms.
As in,
Very much influence the socioeconomic status.
and then the participants for that grouping.
Yeah, how do they populate?
Not in the questionnaire, but when we actually trained the nurses to collect the data, they were quite keen on qualitative data. So maybe in the future, if there's time and bandwidth, and it would be interesting to have in the questionnaire that we're doing now, no. But it would be really interesting to understand that, because one of the questionnaires we're doing is water insecurity. And there are some clinics where over 70% of women have indicated they're water insecure. So there must be some kind of coping mechanism. And we've heard from the nurses that now in some areas, the pregnant moms have to bring water with them to give birth. And so things like that have been changing. So it would be really interesting to know, but it's not formally assessed.
So thanks again to Leyla. Rashida, you're around. I think you've got meetings most of it already.
Yes. I really appreciate the expertise. We've already heard from several colleagues here. So, I think the other thing to just say is that the data's there, the platform's there. We can certainly add on within the limitations they stated. The idea of future analyses as well, I think, and certainly for, I think the extent of sampling that we could definitely manage would be a blind spot. It sounds like from what George said, it would be quite a bit that would be done, either in a case control design or as a cohort. And there are sparse genetic data from